So some of the myths around pumps, they're not an artificial pancreas. We're not there yet. There's lots of technology that's getting it closer and closer, and they've recently released a closed loop system overseas, of course. So we're watching that with great interest, but it's not an artificial pancreas. So it doesn't eliminate the need for testing. If anything, it's more testing than ever. The pump doesn't know how much insulin the patient needs. That comes about through lots of testing, resetting the pump to deliver the amount that you and the patient have worked out. And the other thing the pump doesn't know is when the insulin requirements are changing. So the pump doesn't know if the patient is exercising. The patient has to preempt that and set a lower basal rate for that period of time that they're exercising. So it does take some planning to use those features well. So who is eligible? So the PHARMAC criteria is type 1 diabetes for at least 6 months. It also includes patients who've had a pancreatectomy, so not making insulin, who have cystic fibrosis-induced diabetes or permanent neonatal diabetes, or if they were on a pump before September 2011, which is when the PHARMAC funding was started. The prerequisites are that patients need to be carbohydrate counting, they need to be actually using it and competent with it. They need to be under the care of a diabetes multidisciplinary team who've got experience with managing type 1 diabetes, and they need to be evaluated for whether they're suitable for a pump by that team as well. They need to be already on intensive multiple daily injections using analogues, so that's your Humalog or your NovaRapid and Lantus, for at least 6 months. And in addition to those, then either the problem is that they have their HbA1c is running too high despite their best efforts, so unpredictable and significant variability in blood glucose level, and that the applying specialist believes the pump will improve their HbA1c by at least 10 millimoles, which is 1% if you're used to the old HbA1c measurements. And their HbA1c needs to be in the range of 65 to 90. So basically what PHARMAC is saying is if it's over 90, they're just not taking their insulin. They just need to start injecting. The pump's not going to solve that. And if it's under 65, it would suggest maybe they're having a lot of hypos. Then the second criteria, so if your patient doesn't fit the HbA1c, it could be because of a lot of hypos. So PHARMAC have stipulated that it needs to be at least 4 unexplained severe hypos over a 6-month period, and that the applying specialist believes that a pump will reduce the severe hypos by at least 50%, and that at the time of applying that their average HbA1c is over 53 and less than 90. So they've brought in that 53 cutoff point because often patients who run themselves too low just need to back off their insulin, their injected insulin. So they've stipulated that HbA1c for that reason. If an applicant is approved, then the patient is issued with a special authority. And since about June of this year, the applications can be made online by a specialist or a nurse practitioner who works in the area of diabetes. And that initial special authority for pump consumables is for 9 months. And then if they're meeting the criteria, either the HbA1c or the severe hypo criteria, then it goes to 2 yearly. And those renewal applications can be made by a specialist or by a GP. So under the HbA1c criteria, the special authority will be renewed as long as the patient can demonstrate that they have lowered their HbA1c by at least 10 millimoles and they're maintaining it, they're keeping that going, and they haven't had a consequence increase in severe hypos as well. If they're under the severe hypo criteria, then they need to continue to maintain reducing the number of severe hypos, but they also need to make sure that their HbA1c hasn't suffered as a consequence and it doesn't increase more than 5% from baseline. So the patient will be issued with a special authority for a pump, which is valid for 4 years, and they can reapply every 4 years at this stage. And they have a separate special authority number for pump consumables, and they're entitled to a prescription every 3 months, which usually they'll get through their GPs. So each prescription, they're entitled to 3 boxes of infusion sets, so that's 30 infusion sets. So basically it's allowing to change an infusion set every 3 days over that 3-month period. 3 boxes of cartridges or reservoirs, again, so they're changing every 3 days over that 3-month period. A battery cap every 6 months, which that helps make sure that the pumps retain their waterproofness. And patients can also get 1 extra box of infusion sets and cartridges each year. But it has to be written on a separate prescription. You can't have 4 boxes of. I'm not sure why, but that's how it is. And the prescription forms, as you've probably found, are not the same as a normal prescription form. They have to be specific to the type of pump that the patient is using. So they can be downloaded from the website. So if the patients are on an Animas pump, you can just go to the NZMS website and go onto the insulin pump therapy resources for healthcare professionals and then click on ordering and then the prescription form, and it will print off the prescription form. So are you all familiar with that form there? So that lists all the consumables, which can be really confusing, and often the patients won't know the name of the infusion sets they're on. So a simple way of working it out is to ask them, is it metal, is it Teflon, is it angled, is it straight? And then you'll know from that which one to go for. And similarly with the Medtronic pumps, go to that website, and at the bottom of that web page there's a tab for downloads, which you click on that, which will eventually take you through to their prescription page as well. And then the patient just takes that along to the chemist and gets that filled. So the ideal candidate is something of a superhero. They need to be pretty motivated. They need to have realistic goals about what the pump can and can't do. They need to have the intellectual capacity to actually operate the pump and be able to self-manage on a pump. They need to be willing to test and record their blood glucose levels, their insulin doses, their carbs regularly, and analyse all of that. And they need to be pretty proficient at carb counting as well. So in our experience, what we've found is the patients who do well on pumps are somewhat obsessive, fairly tech savvy, but basically the patients who can manage a cell phone are going to manage a pump. They need to have that ability to be thinking like a pancreas and understand when to reduce insulin, when to increase it. They really do need to be proficient with carb counting, and it's really important they learn that before they go on the pump. Otherwise it's too overwhelming trying to learn carb counting and master a pump at the same time. They need to have the ability to analyse and troubleshoot, and a willingness and ability to self-manage and be independent with their pumps. The ones who haven't done well are those who've often come in with unrealistic expectations about what the pump is going to do. If they don't test, they're just not going to do well. They don't really understand their diabetes or how insulin works. Certainly if they're not carb counting, it's just a guessing game, and they end up taking exactly the same doses as they would have by a pen, so there's really no point in being on a pump. If they haven't had good formal pump education, so in the past A lot of patients were just commenced on a pump by a rep, half a day, and off they go. And they really have not done well. And if they don't have good support as well. So you're probably starting to see a few pumpers coming into your areas. But you're not expected to have to start people on pumps or troubleshoot pumps or really have to deal with pumps. So if patients are having issues with their pumps or having poor control, just refer them back to their diabetes multidisciplinary team. It is helpful though if you do check their cannula sites for lipohypertrophy, because that's one of the biggest problems with pumps, of not people not rotating and then developing poor control because the insulin's not being absorbed properly. So they're most likely to be contacting you for their prescriptions, for repeat consumables and for special authority renewal applications. Just be aware that the type of infusion set they start on, they may change to something else. And that's why, even though you might have a letter saying they've started on a contact detach infusion set, it would pay to ask them what they're on now, what they would like, because they might have decided they want to try Teflon, or they want something so they can get round to the back of the hips, or for a lot of them develop an allergy to Teflon, which sometimes manifests straight away, and sometimes it might be a year and a half later, so they'll switch to the metal cannulas. And some people like to have a mix in their 3-box per prescription, so they might have angled Teflon for the front, and then they might use metal for back of the hips, for example, is quite common as well. The other thing that's quite useful would be just to check with them, do they have a backup kit? This is really important if they have a pump failure. And pump failures tend to happen at the most inconvenient of times. I had a patient who went on a sailing holiday way up north, and of course he fell off the boat on Good Friday and he had no backup insulin and his pump was lost, sank to the bottom. So what was a major inconvenience turned into a major crisis, and he had to drive for hours to get to the nearest hospital to get some insulin. But if he'd had his backup kit, he could have averted that. So a backup kit would be a little kit like this that we encourage patients to carry with them everywhere. So of course they get sick of that after the novelty has worn off, but at the very least they should have a syringe and some insulin. So I could even put that into their blood glucose kit so that they can give insulin if the pump dies. And they would just need to give every 4 hours the amount of basal that's missing with that. But if they had a full kit, it would be really useful to have a spare infusion set in case they rip out a site and they can replace it, something to clean the skin with, maybe something to clean their hands with, a spare cartridge, and some ketone testing strips. Testing for ketones is really important because that tells them if they've got a high blood sugar and their ketones are negative, the high blood sugar is probably due to they didn't have enough bolus, or maybe they're a bit stressed or a bit unwell, or their basal isn't quite right, but they're still getting insulin, they're just high. But if they've got ketones, they're not getting insulin. That's the most common reason. So that's quite a different scenario. That's a much more serious situation and they need to change everything out. So really important. It's also really useful to have an up-to-date list of what their total daily basal doses and ratios are. And that's so that they can give insulin via a pen or syringe using those doses. And that's what a backup plan is all about. So pump failures can happen at any time, and as we know from Christchurch, civil emergencies can and do happen, and patients really need to be self-sufficient for up to a week. So they need to know how to convert back to multiple daily injections. And this can be easily done if they know what their current total daily basal dose is. That amount they would give as Lantus just once a day. If they've only just started on a pump, they might recall what their Lantus dose was. They could use that before they started on the pump. But as long as they've got that recorded somewhere, it'll give them some idea of how much long-acting they need. And with rapid-acting, they can either use the current ratios that they're using in their pump, or if they've recently started on a pump, or it's the only thing they have got written down, use the ratios that they used before they started on the pump. But they need to have that recorded somewhere, because if the pump dies, the whole thing, like this one, will not turn on. It's gone. With all its history, all its information, it's gone. So they do need to record that. So in summary, it's a great tool, but we're not quite there with an artificial pancreas, and it can't think for the patient. It's not artificial intelligence. It does provide much greater flexibility than multiple daily injections in terms of lifestyle and flexibility and being a bit more spontaneous, being able to exercise when they want without fear of hypos. And it certainly can improve glycemic control enormously, but as you can see, it's not for everyone. Requires a lot of work and a certain level of intellectual ability to manage it. Just a reminder about the PHARMAC criteria. It's either under HbA1c or severe hypos. There's no longer the other category that there was before June when the applications went electronic, and that the special authority renewals can be done either by a specialist or by the GP. But to get that renewal, the patient needs to demonstrate that they continue to maintain benefit with the pump to get ongoing funding. And that's it. Are there any questions? Hi.
How safe is the pump when it comes to contact with water, like showering or swimming or water sports, where there are many children? So what could I advise?
The NMS pump is waterproof. Something like, on top of my memory, it's something like 6 metres for 24 hours. I'd be a little bit more worried about the patient's life than the pump. And the Medtronic they promote that as being water resistant. But most people take their pumps off when they're showering or water sports, so it's fine to be off a pump for up to an hour. Because if you're in the shower, where do you put it? You straddle it between your knees, or just take this. It just attaches so much easier. And same for water sports. They usually just detach. It's easier. Yeah. So it's more risk of falling in water, that kind of thing. Yeah.
I've got 2 questions. If the pump fails, because you're giving rapid acting, how long, and you have to go back to a basal,
Yeah.
how long do you have to wait before you give the basal? Is there a time frame?
No, really probably closest to morning or evening, just to get into a pattern.
Okay.
So you could just do 4-hourly rapid-acting insulin until, say, if you came off at lunchtime,
Yep.
and you decide, we'll take the Lantus at bedtime, because that's what we used to do,
Yep.
just 4-hourly rapid-acting to cover the basal that's missed,
Yep.
and then take the Lantus at bedtime
Cool.
and just continue on.
Okay.
Yeah.
And I looked at, and you, sorry, this is the second question.
Yes?
You talked about carb counting, and I
Yes.
looked at Flossie's meal of 84 grams
Yes.
of carb per night, which seemed a lot to me.
Yes,
When
yes.
you
I
were doing
should
the
point
carb
out,
counting.
not advocating that as a typical lunch. It was just to show adding up lots of different items and what has carb, what doesn't have carb. So it was just an example.
No.
It certainly was not an example of a good healthy lunch.
No. Do you give recommendations in your carb counting course of what sort of carb amount they should have per meal?
It's a good question actually, because there's a lot of interest now in low carb diets.
Absolutely.
And certainly if they keep the carbs to around 30 grams or less at a meal, it means there's a little more. If they don't get the carb count quite right, the insulin dose isn't going to be so hugely affected. But when you get to large amounts like that, if you get it wrong, it means the insulin dose can be well out. So there's certainly a move in that direction, and some dietitians are very keen on that, others not so, because patients have enough restrictions in their life without saying you can only have 30 grams a meal. So a lot of it comes down to patient preference. Some patients love that control, and you know, some of them are really obsessive.
Mhm.
You know, and I've got one patient who would have no more than 12 grams at a meal. I mean, he was over the top. And others who would be like Flossie. So it does come down to what the patient wants.
That carb counting, does it matter about the simple sugars and the...
Yeah, to some degree it does, yes, yeah. So the glycemic index comes into play there, and so the lower the GI, the better, because you're not getting that quick rise in blood glucose levels, because a bolus is just going to follow its normal pattern, its action profile over those 4 hours, and you can't speed it up. So if their blood glucose rises quickly, it'll stay high until the bolus catches up to it. So yes, we still try to promote low to moderate GI meals, yeah.